and good evening or good afternoon to everyone. Thank you very much for joining us. And today we're talking about therapeutic options in COVID-19. Now, this was out of a conversation that I had with Dr. Ring in the week, and I thought, why not bring that conversation live, where we're sharing thoughts, exploring ideas as to what's going on in COVID-19. And so this afternoon, I have two people with me, the pleasure of sharing the stage with Chris, hi, and Scott from the USA. We're very happy to have you both here. And I'll just quickly ask you, Scott, to just do a quick introduction about yourself and your interest in COVID-19.
Sure. Hi, I'm Scott Freeman. I have a PhD in cancer biology from the University of South Florida through the Moffitt Cancer Center. Subsequently went on to the FDA, and I worked in pharma consulting industry. My interest in COVID-19 really stemmed from when it first started. I reconnected with an old postdoc buddy of mine who overlapped with me, and both of us were just, as everybody was, shocked with the entire thing. And we just thought, wow, if there, anybody who's a PhD in the biological sciences or an MD, if there was ever time to put your training to practice, it's right now.
Wow, that's absolutely true, Scott. And what about you, Chris?
Hi everyone. Yeah, I'm Chris Ring. Thanks for inviting me on. I started my career in a diagnostic microbiology lab, and fairly quickly got interested in diagnostic virology. I then moved on from there and did my master's and my PhD, focusing on Epstein-Barr virus. I then did a couple of postdocs in London, UK, firstly on hepatitis C virus diagnostics, and then on papillomavirus. I then moved to Cancer Research UK, once again in London, where I developed some viral vectors for potential use as anti-cancer treatments. Once again, dealing with viruses, but using them as tools rather than sort of studying them as agents of disease. I then moved on to GlaxoSmithKline, where I worked on, a number of projects, but sort of early and late stage antiviral development. I was working on antiviral drugs or developing antiviral drugs for respiratory syncytial virus and influenza. And then I then moved on to my current position at Middlesex University, where I teach medical microbiology and infectious disease to the students. And why am I interested in COVID-19? Well, it's a key problem. It's relevant to today, and it's posing a huge challenge for the entire world. So that's why. Before I got to when I first showed an interest in virology, my colleagues said, "Why would you be interested in viruses? They're merely sort of artifacts," and it's clear that they're from the past year that they're clearly a lot more than that. So that's why I'm interested. I keep a keen eye on the literature, but I would never consider myself an expert. But hopefully, I can contribute something positive today.
Wow. Yes. Listen. This is a conversation, and this is what I want everybody to do: is share their thoughts, put forward their thinking in the context of coming up with innovative ideas, explaining concepts, and sharing it to the public. So the first thing that I would say, Chris, is that you had raised the point when we were talking. You asked me when we had our last Plan B meeting last week. You said, why do we need a Plan B? Is that still your perspective?
Well, I have a clearer understanding of where you were coming from now. But after I saw that meeting, yes, I was thinking, why do we need a Plan B? Because, obviously the world is in an awful situation. Some parts of the world are in a lot better position than others. But, we are making, or certain parts of the world are seeing real progress in controlling this infection. In terms of the global stage, we're still a long way to go. But, we have made real progress in terms of developing vaccines. Of course, there's an issue of rolling that out across the globe. I appreciate that. But what we have developed are working very well, far better than perhaps we would ever have expected. So, I saw things were even though we're in a terrible situation, that there's some positive things there. So yes, that's why I was asking, why do we need a plan B? Why not just continue with what we're doing?
Absolutely. So what do you think, Scott? Any thoughts on that?
I may have had a dash of pessimism with that. I was kind of worried from the beginning when I heard that all the major vaccine developers were targeting only spike, the most mutation-prone region of the virus. And I was hoping that they would use a multi-epitope approach, that if they did include spike, that they would at least do due diligence and possibly compare it with the spike of what I guess they call now the original SARS-CoV-1, and try to find regions of homology, which may indicate functional regions that would, not be so prone to mutation. And then possibly look at sera from infected individuals to look at other regions that the body is targeting naturally, such as N and MP, M and NP, even the open reading frame regions, and come up with maybe a 5 to 10 epitope strategy.
Hold on, Scott. That sounds pretty complex. Are you just saying that the spike protein has multiple points and they should be targeting different parts of it?
No, I'm saying spike I would say, not my first choice that I would target if I were concocting a vaccine against SARS-CoV-2.
Any thoughts on that, Chris?
Well, yes, in that I would say that to target the protein which binds to the cell is the obvious target to go for, and it is fairly a consistent strategy with other vaccines. Having said that, because it is so key, and the immune response targets that protein very effectively, of course there is huge evolutionary pressure for that protein to change. So as well as it being the obvious target, there are reasons for not choosing that. And I'm very aware that a lot of the vaccines that we use currently are based upon, in effect, the whole virus particle, whether it be an inactivated form or an attenuated form. Yes, we do have other vaccines available, subunits and things, but a lot of the the really effective vaccines that we have are the whole virus. And I think the evidence that we've seen so far is that there are advantages to including other antigens as well, particularly in terms of T-cell epitopes and coverage against all variants, of which are very much in the news at the moment. There makes sense in including other viral proteins in vaccines in the future.
Now, just to make sure, because not everybody may understand some of the complexity here, is that I usually describe a virus like a football, where the lining of the leather of the football is the nucleocapsid part, and then it has these spikes stuck on it, okay? And normally, the body would produce antibodies to the whole virus. And in this case, especially with the mRNA technology, we are only doing it to the spikes that are stuck onto the virus. Why did they not include some of the nucleocapsid proteins? So it's some of almost the body of the virus in the mix.
Well, I think like I say, it's sort of, the focus is very much on blocking infection of cells. And so that's why the target was the spike protein. But of course, I don't think it's enough just to block that interaction, because by developing antibodies and other immune responses to other proteins means that you can remove the virus in other ways. It's not just a question of blocking interaction with the virus and the cell. By stimulating antibodies against other proteins, then you can remove the virus in other ways by antibodies that encouraging uptake by phagocytes and things like that. So I can understand why there was such focus, but I'm surprised there hasn't been more interest in other proteins.
Yeah, I can understand that, and this is part of the issue. And I'll tell you what my concern is with regards to the vaccine. It's one thing to talk about the spike protein. My concern is to do with the fact that we are not necessarily getting mucosal immunity. Any thoughts on that?
Scott?
Yeah, that was one thing Ingo Frick and I put in our preprint. We wrote a preprint that we tried to get published, and we wrote about, putting in multiple epitopes, and we actually suggested a mucosal route of administration. So we thought that would also be a better way to go about doing it too. So I'm on board with you there.
And actually, I'll tell you what I'll say with regards to this, with the mucosal bit. When we have been doing our research, there's an important piece of the puzzle with COVID that is not fully understood. And that's what we call the asymptomatic phase of the disease. So there have only been about 6 or 7 case reports where people have come in, they were going to have surgery or biopsies done. They had the surgery done, and then about 3 days later, they developed symptoms of COVID. Guess what? When they went back to the biopsy, the changes and the infection was already there. They were asymptomatic, even though the virus was replicating. So this is the problem, is that if we're assuming that this is just a typical virus that causes symptoms, the modus operandi of this virus is that it blocks interferon, it doesn't get detected. This is why we don't even have nasal stuffiness. Can you imagine a cold virus that doesn't cause you to produce mucus in the nose? You have no sore throat, you have no nasal stuffiness. It's unbelievable. It's an absolutely remarkable feat that this virus has been able to evade the typical response for a virus.
Yes. I mean, in terms of vaccines, I think it makes sense to, if a lot of the, sort of original vaccines, the vaccines that we use a lot these days are effectively they're mimicking, or they're trying to mimic a natural infection in some way, except that we're giving them by a very unnatural route. So to try and mimic the infection, you really need to administer the pathogens or parts of the pathogen to the same portal as the natural infection. So from that regard, yes, it makes sense to deliver it to the nose. I'm very interested to see the data that comes from the intranasal vaccines that are in development. I can understand, thinking of other mucosal vaccines, I'm also interested to see what happens with the oral vaccines, because, I can see the advantage of those in terms of route of administration. Yes, they presumably would stimulate mucosal immunity, but perhaps not quite the right mucosal not the quite right mucosa. I'm not sure the logic in actually trying to develop mucosal immunity in the gut, but I don't know. Clearly there are gut symptoms, but it makes more sense to me to administer to the nasal mucosa, definitely.
Any thoughts, Scott, on why, even though the vaccine doesn't in theory produce mucosal immunity, how is it suppressing transmission? Because this is what it appears in the UK and in Israel.
Well, it's still, even though it's not mucosal, it still works. You don't have to have you don't have to be entirely through the mucosa for it to work and for it to be effective. You can still block transmission. It's just, there haven't been variants that have gotten there that are, or the vaccine is effective against the variants that have gotten there. So,
well, go on, Chris. Go on.
Yeah, in terms of, because I did look this up, and I think even with the MMR vaccine, which is a very effective vaccine, that does block infection of the throat from from vaccinees. And that gives very effective immunity and long-lived immunity. And so does the HPV vaccine, which, of course, is once again is not a mucosal vaccine. But that also, and I'm just wondering whether it's a matter of, because some vaccines do stimulate such high levels of antibodies, circulating antibodies.
This is what I'm thinking.
So much of it that the concentrations are so high that it just almost, exudes out of every pore, including into the mucosa. Does that make sense, Scott, do you think? Or
Yeah.
Well, and actually, that is part of the worry, though, because what it means is that whilst the serum levels are up, you will have some protection. But what happens when the levels drop below where they would seep into the mucosa? And this is the point. And I think that it's almost a question of, or I should say, why are we saying openly that the virus, that the vaccine blocks transmission when we don't clearly know? We know it has an impact on mitigating it. But I'm just saying that there is no clear evidence that it actually will, even in the future, completely block transmission.
They're very difficult studies to do, though, aren't they? Really, in terms of it's easier to see whether there's any evidence of infection in the nose or the throat by doing PCRs. But in terms of actually stopping transmission. So you then got to look at contacts and whether they're, it just gets very, very complicated. Yeah. It would be nice to know, but it's incredibly difficult to determine.
Yeah. So I guess my big concern is that when we have a perception that the vaccine is suddenly going to make everything safe and everything perfect, that's why I thought that the plan B was needed. I expected vaccines to mitigate the disease. So meaning that if 100 people were dying a day, it would go down to maybe 50 or 40. But 40 people dying a day is still a lot of people. So you can't then assume that the vaccine in and of itself is the complete root out. That's my thought.
Right.
No, fair enough. That's right. I mean, I have high hopes for it, but really the problem is, I think the key problem is just getting it to people.
Yeah, well, hold on. And as you said, getting it to people is that there are 7 billion in the world, okay? And what I find interesting is that if we had used the vaccine for the most vulnerable in the world, we would have probably targeted the most vulnerable group across the world, because we've done about 800 million or something like that vaccinations. But instead, we're having situations where in some countries we're going down to children. Now, explain that to me.
Well, I assume it's to try and develop some sort of, increase the population immunity to such a level that it's going to stop the virus circulating and getting to particularly susceptible people, but rather than just targeting the most susceptible people.
But the point is that this is now become vaccine hoarding. This is a first world solution. It's not a rest of the world solution. Is that reasonable?
I fear it is, yeah.
It's a reasonable suggestion, but it's not reasonable.
But isn't that what it is? Let's be honest here. When you look at the difference, 1 in 4 people in a first world country have been vaccinated compared to 1 in 500, say, in Africa. What is that?
Capitalism.
And can we see any other, if we have variants come out and we need to adjust the vaccine, who is going to get the vaccine?
First world countries first.
So this is what I'm saying, is when I thought of a plan B, I was saying that I can see how this works. You know, if we need a variant vaccine, you then give the rest of the world the first version that doesn't work quite as well, and the first world gets the new one. Is that about right?
That could be, but I mean, that would be thoroughly unethical, would it not?
Yeah.
But isn't that what's happening? It's not even about what we think will happen. Isn't that what's happening?
Well, it's what you mean in that the first world countries are getting the vaccine and everyone else isn't getting it. Is that what you mean?
That's exactly what I mean.
Yeah. Well, that's a real difficult one, because I can see the countries that are funding development as feeling that they have some right to first dibs of the product.
Mm-hmm.
Not that that's the way that should be done, but it's.
But that's the way it is. And so this is what I'm saying, is that whilst we're talking about a plan A being vaccines, the reality is that plan A is not necessarily plan A for the world. It's a plan A for countries that can afford it.
Well, yes, but then that's the same about any aspect of healthcare. I would say that private healthcare, if people can afford it, they can get it. Everyone else has to put up with what is left over. So it's sort of inevitable. I think that as much as I think we do need to think of other means of dealing with this infection, we also need to try and convince people for more equitable use of this vaccine as well. But
yeah, that's one thing. So let's jump on to something else. And I wanted us to talk about something like steroids. Any thoughts, Scott? Any thoughts with regards to steroids and COVID-19?
I like dexamethasone. It was the first thing to really be shown to be effective. It can work through two mechanisms: short term through directly working through transcription. It can work at higher doses through a more long-term method, but I think that should be considered to be used alongside any other potential treatment. I think it's really the evidence has shown that to be the most effective drug. Really.
And so I'm going to put the challenge to you now, Chris. Now you are a virology guy. You tell me which other virus we have got that we have first-line drug steroids for.
So you're talking about virus infections?
Well, I'm saying I'm saying that should not make any sense.
No.
How can we be using steroids as first-line treatment? It's actually working.
Yes, but I think we have to draw the distinction here that this disease is very different from a lot of other conventional virus infections, where probably in all infections there is an element of some level of damage caused by the pathogen directly, and some level of damage caused by the host response. That I'm sure there is an element of both of those in any infection. But this one in particular, I would say, that we're considering here is that the majority, or the symptoms, my understanding, are caused by the host response. And so therefore, but it's still triggered by the virus. Now, the virus is doing minimal direct damage, but it's triggering the host response, and that's what does the most of the damage. So it makes sense to use something which is going to dampen down the host response. But I think you have to be very careful, because, of course, drugs like that are also going to suppress the antiviral response. So if you give it too early, that could, exacerbate the problem, I expect, in that you're going to allow more virus to be produced in the host. So you're right, for virus infections, you generally will not use immunosuppressants like that. No.
No,
but there are just to certain things like encephalitis, for example. You need to bring the intracranial pressure down, and I understand that steroids are used for that. But once again, that's dealing with the symptoms, not the actual infection. But so in that example, of course, you have to bring down the intracranial pressure, otherwise your patient's going to die. So, it may not be ideal in terms of allowing viral replication, perhaps a bit more than you would want, but, you have to keep the patient alive. So,
yeah, so I'm going to throw a challenge here to you guys. I looked at the numbers in the UK, and out of the 127,000 people who died, it's not a surprise that people over 85 with what we would think are weak immune systems died, and 57,000 of them died. But guess what? Do you know how many infants died in COVID-19? Two under 1-year-olds died in COVID-19. Now, that does not fit the narrative of a severe viral infection.
No, you're right, but there's no. I agree, but that just tells us something about the pathology, doesn't it? That it's not primarily the viral replication which is doing the damage. There's clearly a lot of other things going on in those older people, and I'm not sure it's just a question of immunity as well. I mean, a lot of people say, old people, they're losing their immunity. Yes, okay, relatively their immunity is waning, but some people talk as if you get beyond a certain age and you're effectively immunosuppressed. I don't believe that. I don't know, Scott, is there any actual evidence for that?
Well, I mean, you do see it. It's almost a little bit of immunosenescence that we would say.
Yeah.
So as you get older, you do have, and it's not for every patient, but the majority of patients who are frail, their immune system doesn't respond in the same way as a young person. And we tend to see it in things like the CRP and so on. And so in that sense, I would have expected for a virus that has killed over 2 million people across the world and is apparently that lethal, we should have seen far higher infant deaths. And this is where it's going, is that my challenge is that I have always said from the start that this is an viral mediated autoimmune disease, which is why steroids work. Yeah.
I don't deny that, actually, but whereas from my virological standpoint, I'm agreeing with you that it's not primarily the action of the virus, except that the virus is triggering that autoimmune response.
Absolutely.
And so therefore, I agree with you that we need to treat that hyperactive host response in those susceptible people, but we should also be targeting the virus because that's the trigger of that as well. We shouldn't throw out the virus and not target the virus because that's the initial trigger.
So it brings us right into the Remdesivir. Any thoughts on that, Scott, before I harass Chris?
No, I was gonna let Chris take that one. That's his area of expertise.
Yeah, all right. Yeah, you need to tell me why this drug, which from the start didn't show an impact on mortality and it only reduced hospital stay. How in the world is that still a part of our regime?
That's for me to take?
No, let Chris go with this one.
I'm going to have a slurp of coffee and then let's stop.
Okay. Oh, you want me to take that one?
Yeah, why not?
It may have been timing of administration. With a lot of these current generation antivirals, they have to be given early. Think of Tamiflu. If you don't come in with symptoms, within the first 24 to 48 hours, they're not even going to give it to you.
Yeah, absolutely right. And when you add that into the fact that the first 4 to 5 days of this virus are asymptomatic, by the time you're throwing Remdesivir in the mix, that horse has not even bolted through the gate. It's gone into another country.
Yeah. Yes. I think as I said when we spoke earlier in the week, that, out of desperation, everyone is throwing everything at these unfortunate people that are in such a bad way. That, out of desperation, we need to keep these people alive. And so, what's on the shelf that we can possibly use? Let's give them that in the hope that will work. And that's wholly understandable. But we have to be more careful how we test things than that, rather than just giving everyone that, because as Scott has said, with any antiviral, you have to give it early, because you've got to give it when the virus is replicating and hasn't been stopped from replicating by just the normal sort of host immune response. It's no longer going to be susceptible to those agents then. And I suspect, as Scott said, that in trials, Remdesivir has been used too late. So in other words, you could almost predict it wasn't going to work very well. I suspect if the trials were done differently, if it could be given earlier, then I suspect we would see more of a response. But of course, part of the problem with Remdesivir is that, of course, it's you have to give it parenterally, which doesn't lend itself to be given early in the infection. Some of the newer drugs in development, of course, can be administered orally, and of course they have the edge in terms of administration anyway. They help in that they probably can be given at a point of the infection where they're more likely to work.
And so, are there any antivirals?
Why Remdesivir got FDA approval based upon the data, I have no idea.
No, this is the kind of thing that dismantles the trust in the system. I mean, I agree with you completely as to how it was possible for it to get as far as it got. And we'll come to things like Ivermectin in a little bit later on. But that's incredible. And any other antivirals, Chris, that could, you think, make a difference?
Well, yes, I think so. We've got Molnupiravir, which is a ribonucleoside analog, which is in phase 2A at the moment, which I think is looking quite promising. That's the one I would say closest to approval, although we obviously always have to be careful of these things. They can drop out at any time. But then, of course, in addition to that, we've got protease inhibitors. Protease is a favored target, I would say. It's essential for the viral replication cycle. There's no known sort of human analog of the protease, which is good in terms of potential toxicities, of course, to using drugs that target that protein. And they're not quite as far ahead. They're still in phase 1, I believe. But and this is like the Pfizer drug, for example, 1332. And there's some other ones as well. Can't remember who's actually developing those, but other main protease inhibitors, which certainly are looking good in vitro and in animal studies. So there's some things in the pipeline which are looking promising, and they're orally available. They're being certainly the Molnupiravir has been tested. Obviously, it's in phase 2, so it's shown. It's looking promising in terms of reducing a viral load in patients just after sort of 5 days of oral administration. So, and this is in people that have turned up to the clinic with symptoms of respiratory infection. And fever, so that have obviously been shown to have SARS-CoV-2 infection. So I believe that there is still an opportunity there to give.
I can see the point with that, Chris, but as I said before, by the time we even see evidence of the virus, it takes from the time the first infection happens, 10 hours for it to do its first replication cycle. In 20 hours, it is completely over the lung with no symptoms. I think that the challenge you have is unless you know someone was exposed and you give them the antiviral almost prophylactically, you're going to miss the boat. But it leads us to another point, though, which is I can never pronounce this thing right. I'll let you pronounce it, Scott, because I'm going to ask you to talk about it.
Tocilizumab?
Yeah. That weird
sounding one. Say that again. Say that you do that.
That sounded pretty good. Go
ahead. What's it? Say it again.
I don't even know if I'm saying it right, but I say Tocilizumab.
Yeah, that sounds right. So what is this, and how in the world is this involved in a viral infection?
It's a recombinant humanized IL-6 receptor monoclonal antibody. It was approved by the FDA for the treatment of some rheumatological disorders and cytokine release syndromes induced by chimeric antigen receptor T-cell therapies. And it's actually under the NIH COVID-19 treatment guidelines. So there's enough evidence based on the REMAP, CAP, and recovery trials that it's recommended to be used in combination with dexamethasone for the treatment of COVID-19.
So again, I ask the question, here we are, the two most valuable drugs in a viral infection are immunosuppressive. And I've been saying for a year now, this is an autoimmune disease. What is so difficult to understand about a virus triggering an autoimmune response?
Yes, but a lot of viral infections trigger a damaging host response. Now, I admit that this is a particularly extreme response that is triggered by the viral infection, but I don't see that's such a big deal. It's a virus infection which triggers an aggressive host response, which results in the disease.
Hold on. But it's a viral infection that triggers an aggressive host response in only older people.
Okay.
Not in young people, not even young people who are immune suppressed. That makes no sense.
Well, I'm not sure whether it makes sense or not is relevant, to be honest. It's just that, we have to target our treatments to the most susceptible for whatever reasons they're more susceptible. But it's still the virus which triggers it. Now, so I don't see there's an issue there. Are you saying we shouldn't be targeting the virus then because the virus is irrelevant?
No, I'm not saying that the virus is irrelevant, but I'm saying that what we have done is that we have not actively focused on understanding the disease at the level that we should. So I have argued for a long time that because of the fact that you have this asymptomatic part of the disease, we should be doing autopsies on anybody, especially younger people who have died and who are positive, to study what the heck is happening in the lungs. Because without that information, we are absolutely guessing. When they look at the animal models, so they'll take chimps, and they'll take ferrets, they'll infect them with the virus, and guess what? Within 48 hours, the virus is all over the lungs. It's causing the inflammation, there is edema, but there are no symptoms. That's the problem. And so this is what I'm saying. If this is happening across the board, and even when they looked at children and they did the CT scan with children who had no major symptoms, I think up to 70% of them had lung, ground glass changes in the lung. Again, with minimal symptoms.
Don't children get purpura? That's autoimmune.
Yeah, it is autoimmune. Yes.
So they should get autoimmune COVID as well, right?
Interestingly, all they get is that. They don't get the other symptoms. And this is where Mhm.
What about the children that get the MIS? What's it? MIS?
Yeah,
MIS?
am
That which is not quite the same as COVID, is it? It's but we should be looking in those patients, surely, shouldn't we?
Yeah, I agree. And this is part of the problem, is that I think that what we're doing is that we are trying to manage a disease that we don't understand by throwing drugs at it. And I always said, fundamentally, if you do that, you're going to run into problems. And I would say categorically that COVID-19 is going to be turning out to be the rheumatic fever of viruses.
Yes, but I can see where you're coming from, but you can't wait around until you know everything about a disease before you start trying to manage it, can you?
No, I agree.
I'm sure you're not saying that, but
I'm not saying that.
We have to try and treat this as best we can, admittedly in our relative ignorance about this subject, because we need to help people. But
we are not a few months into the disease. We are now over 14 months into this disease. We have spent billions of dollars developing therapeutics, and we haven't put a fraction of it into studying the disease. Do you know that we're still not doing autopsies on the majority of people who die with COVID? We're not doing basic medicine.
Why is that?
I think it's because I don't think the funding is in place. It would have to be at a national level to be able to get enough pathologists to be able to be doing the slides on top of their regular work. Because remember, in the system, people have their own workloads. It would have to come right from the top. But this is what I'm saying, is that we are making fundamental errors with understanding the disease.
Yes, I mean we do need to do. I agree, because there is only so much you can tell from animal studies. Let's face it. I mean, for whatever we do, and we have to do animal studies, and of course, even though I'm saying that some of the the evidence coming from antiviral studies in hamsters or whatever the animal model is looking promising, that is of course in an animal, and an animal is not a human being. So you're right. We do need to do these experiments on human tissue. I agree. I didn't know whether there's also concern about, infection risk or something like that.
Sounds like a good topic for a grant application.
Yeah. So let's go on to one of the more controversial ones. Ivermectin. Any thoughts?
I'll have a cup of coffee. Scott?
Oh, boy. Ivermectin.
I just want to say, actually, I don't know why people are so interested in it. I can't see I can't see a lot of evidence that suggests it works at all. Am I being heretical now, or what?
Well, listen, I haven't studied all the meta-analysis, but I certainly know a lot of the work done by FLCC, who have been promoting the point of ivermectin, and it is being used across the world, certainly in the developing world, as a therapy, and a lot of people have said that it has helped. I guess my question has always been, how can a drug that is used to target helminths help in a viral infection, even though it did show that it had some activity against the SARS-CoV-2 virus, but this was at pretty high doses in vitro. So the mechanism, as far as I'm concerned, cannot be along the antiviral route.
This is my problem. There just hasn't been a lot of research.
Yeah, I mean, just because it works, it has a particular mode of action against helminths, doesn't mean that there aren't other mechanisms that it can use. And, it must be a different mechanism. But do we really have a good understanding how a lot of the drugs we use work?
My thought is simple, is that what I've said is that the mechanism of death in COVID-19 is not about the viral inflammation. It's about the thrombi in the lungs. So the clots that form in the lung blood vessels is what kills people, because you literally have to go down to about maybe 12 or 15% lung capacity in order to die on a ventilator at 100% oxygen. And so it can't be the viral inflammation that is doing that. And all of the autopsies seem to suggest that the most characteristic thing with COVID is the microthrombi. So some of the experts or people who I've listened to, and I'll come to vitamin D in a little bit, have just suggested the fact that ivermectin may have an impact on reducing fibrinogen. And if fibrinogen goes down, you have less microthrombi, and therefore you're more likely to survive if you've got lung inflammation.
Mm. I couldn't help but notice one of our viewers just put something in the chat there, which I wasn't aware of, but seemed to see if I remember it correctly.
Yeah, which one's that?
There's evidence that there is some evidence that ivermectin works better in areas of the world where there's a real burden of helminth burden. Now you could argue perhaps, and I have no idea whether this will be true, but of course if the burden which helminths have on the body, if you deal with that problem, they may be less susceptible to the symptoms of COVID. We've had this, this was a lot of the discussion in your last meeting, of course, that, if you do things to basically, increase people's overall health, if you can do that. And of course, there've been other things suggested like the D3 and the vitamin C and giving iron and things like that. And of course, iron deficiency is a key pathology, is a key effect of helminth, increased helminth burden. Then if you deal with the helminths, that might have an effect of increasing people's overall health and ability to resist disease generally. And so could that be the effect, that it's not actually the drug acting on the virus as such, but it's having some beneficial effect on the host's ability to resist the effects of that infection?
No, but at the same time, I have to ask the question: how can you have a drug that looks as though it may be effective, even though we can't explain the mechanism, is being used across the world, is relatively safe and cheap, not being given approval, yet we did something like approving Remdesivir? How do you explain that?
I can't. I can't.
This is the kind of thing. So it leads us to one of the other questions, which is very similar to ivermectin then, which is that of vitamin D. Okay. Any thoughts on that, Scott?
There's a lot of studies that show it doesn't work as a treatment.
But does it work as a prophylaxis?
Probably.
I think there's more evidence, isn't there, that it will be prophylactic.
Yeah.
And if it is, use it.
Yeah.
I mean, to me, it's a no-brainer. If somebody is vitamin D deficient,
Oh yeah. If you're vitamin D deficient,
of course, you need to replace it, and so that's part of it. But again, as I said before, what kills people is not the inflammation in the lung; it's the thrombi. And what happens with vitamin D is that vitamin D has an inverse relationship with fibrinogen, which is the final stage of the clotting cascade. And if your fibrinogen levels come down, you're less likely to make clots. Nothing complex. And to me, therefore, if you have somebody who's vitamin D deficient, and it's well known that vitamin D deficiency is associated with DVTs, clots on the lungs, and stroke disease. And if microthrombi are a part of COVID, then vitamin D is likely to have an impact on it as well.
Yeah, no, I personally take D3 and K2 myself. So.
Yeah, I mean, it's one of those that I guess it's a no-brainer, but I can't figure out why it doesn't seem to get the support. I mean, it's the kind of thing that you'd think. It's one thing to say you don't think that it's going to make a huge impact. But what I seem to see are studies saying that it has no benefit. And I'm thinking, why are you saying that it has no benefit when vitamin D is an essential vitamin?
I think the studies I'm referring to are the ones where they give it to hospitalized patients in large doses, and they don't show any difference in mortality or dropping off the ventilator or anything like that. Like the two most recent ones that were published in JAMA. So
I think. Go ahead, Chris.
No, I was just going to say, well, that just suggests to me then that it's not a therapeutic, but it's a
right.
prophylactic.
Yeah, exactly. Yeah. So too.
And I think that's quite reasonable. So let's move on to here's a question that I think is quite relevant, which is there any role for aspirin?
I'd say absolutely. Well, yeah, I think so. I think the evidence points that way.
And what about colchicine?
Just because of the trial that dropped it, I'd say there's a lack of evidence. Well, not just because of that, but I would say that there's not enough evidence to point there.
Any thoughts, Chris?
It's not my area of expertise, but so I shouldn't say too much. But what is the evidence that why was colchicine used in the first place? Why was there any interest in that?
I think it was the anti-inflammatory action. So, say for instance, colchicine has become of interest even in stroke disease because of the anti-inflammatory and therefore antiplatelet action. So, I think that probably the target is the clotting. Similar with aspirin. Aspirin is antiplatelet. If you reduce the ability of the body to make clots, do you therefore have an impact on the disease?
Yeah. Well, and then it makes sense to try it. But if the trials aren't really holding up, then we need to move on to other things, don't we? Really, rather than spend a lot of time trying to doing lots of studies with the hope that they'll work in the long term, and they don't. Well, it makes sense to perhaps just move on to something else.
Absolutely. But the reality is, when we look at the therapies within the hospital environment, because weren't we using, or do we still recommend doxycycline, azithromycin? Are those still part of our regime?
From what I've read, I don't think they are they? I don't think there's enough evidence that they work. Scott, have you looked at this?
I know Dox is let me see here. Where is it? I was looking at Dox in a paper. I have it right here. Dox and azithromycin say they should not be used.
We were using them quite a lot early in the pandemic.
Yeah, I know that some antibiotics are recommended for when secondary infection with pneumonia, but only when pneumonia has been confirmed as bacterial infection. As far as azithromycin, it says it may reduce cytokine levels, which can promote an inflammation. Evidence from the principal trial do not justify the routine use of azithromycin for reducing recovery time or time to recovery or risk of hospitalization.
I read that there was some evidence of some antiviral effect, although once again, it's a bit like, excuse me, it's a bit like what you were saying, Philip. I have no idea how it would be working. But I don't think there's enough evidence from what I've seen that it would really be of any benefit.
Here, let me put this to you guys. Is this now an embarrassment where we're still fiddling around, shooting at trying to figure out stuff that could work? We're 14 months into a pandemic that closed down the world, where we had every resource available to us. What is history going to say when it looks back in 50 to 60 years What is history going to say about us?
We tried to throw the kitchen sink at this thing instead of trying to come up with rational good drugs. Because I looked at a paper that listed all the antivirals that are being tested, all the immune modulators, and other / multiple mechanism drugs, and there were 64 of them. 64.
Yeah. And this is what I guess I've always been arguing from the beginning, is that we have just gone all guns blazing with whatever we had, and nobody is having a good enough understanding as to how this virus is having an impact on the body. I think that's been our fundamental error. And sadly, over a year in the pandemic, we are still not changing that angle.
Even if we put more effort into understanding the pathogenesis, there's no guarantee that we would come up with a good treatment by now. Although it's probably more likely. But do you think? I mean, I just wonder whether if we'd put some of those resources that have gone to developing vaccines, with the successes that we've had with those vaccines, and taken with the caveats that we've discussed. But if we'd taken half of those resources and put them into studying the pathogenesis, would we have been as far forward with vaccine development?
Well, the only thing I would say is that why do we need 200 companies to develop vaccines? Come on. Yeah. What is the point of that?
Yes. We are throwing everything at that, aren't we? You're right. We're using every possible technology to consider that. No, that's a fair point.
Yeah, I mean, and when you look at it, we've only done a few thousand. I don't even think we've done 2,000 autopsies on patients who have died with COVID. And the bread and butter of medicine has always been pathology. And if we haven't done enough, I don't see how we could ever get an answer that would make any sense. And so this is where, when it comes down to us explaining the way out of the pandemic, I have said is that let me assume for a second, because I think my theory is right with regards to autoimmunity. So I have to say that.
We're not a bit biased, though, Philip. Of course.
Yeah, I'm a bit biased here. but here is the point: is that if that is correct, and this is an autoimmune disease that is triggered, and I said it's triggered by serum ACE2. As sort of I've always said, the same receptor that the virus uses to get to the cell are the same people who are dying who have elevated levels with diabetes, heart disease, hypertension, and their levels are up. What happens when the virus binds to serum ACE2? Does it then become an autoimmune disease? And it's such a simple question that hasn't been asked. We haven't even asked the question of, when we produce spike proteins from the vaccine, how does it interact with serum ACE2? We haven't even asked the question.
Yep. Well, I think also this comes back to where we started with talking about vaccines as well, and about some people's concerns about loading up people with spike protein. And what effect might that have on ACE2 and serum ACE2? Scott, any comments?
Oh, you mean like as in the synthetic decoys, or?
No, I'm just meaning it of just administering lots of spike protein. Could that be contributing to, in some cases, to some sort of autoimmune reaction?
Potentially, if the autoimmunity theory holds true, it could potentially be.
Well, the question would be quite simple. If the spike protein is similar, and it should be, to the spike protein on the virus, we've already demonstrated that the viral spike protein binds to serum ACE2.
Yep.
So if we injected a vaccine that also produces a spike protein that binds to serum ACE2, what's the outcome of that?
Yeah.
It hasn't even been asked. And this is what I'm saying, is that question to me is a fundamental question that has not been asked.
So if spike binds to ACE2, serum ACE2, so effectively sequestering it,
Yeah.
What physiological effect could that have? I mean,
well, what would happen is that if you have the serum ACE2, I think the purpose of the serum ACE2 is to manage aldosterone levels in the blood. It's like a backup mechanism. And so what you would then have is that you would have uninhibited action of angiotensin 2, acting both in the lungs, which is pro-inflammatory, and in the adrenals, which would probably push aldosterone levels up even further. And we don't know. These to me, this is what I'm saying, is those are fundamental physiological questions. So yes, gentlemen, this was quite good. I think we've just hit the hour mark, which means that we've probably run out of our energy and our time. So what I want us to do now as we finish up, I'd just like everybody to close out where they think things are going to go and what they think the future is with regards to this pandemic. You don't mind if I start with you, Scott?
Think or hope? Oh boy. Well, I don't have a crystal ball, but I hope that a mutation arises that binds to ACE2 with really high affinity, but greatly attenuates the virus.
Great. And what about you, Chris?
Oh goodness, that's really putting us on the spot, isn't it? Well, I still have great hopes for vaccine. I think that we will have to modify the vaccines. I hope that the people of the world will see the need for equitable access to the vaccine, and to the modified versions that are going to be more effective at protecting us against variants. I hope that the variants will run out of steam, in that, they can only mutate so far before they lose viability, though we don't know how far that is going to be. In terms of antivirals, as you say, I can't help but be biased that I still think we need to look at antivirals. I'm encouraged by the data that is coming out from the drugs that we're seeing in phase 1 and phase 2. I hope they perform well. There are other things further up in the pipeline, certainly in the protease inhibitor area as well, that could be backups if the current ones drop out. That's what I'm hoping. And yes, I hope also, Philip, that you folks have a better handle on what is going on and can work out some ways of actually dealing with the damage.
Absolutely, yeah. So thank you very much, guys. I mean, I have really enjoyed this. This is what I wanted to get, a thoroughly open discussion, challenging each other, thinking about solutions, thinking about ways forward. And I hope that the audience liked this as well. So thank you very much, guys. If you don't mind just hanging on for a minute or two while we do our closing out. And thank you, everybody, for joining us this afternoon, evening, wherever you are in the world.
Thank you.